Hello, my dear doctor. I'd like to talk on a very important topic. That is the PPCM, that does mean the Peripartum Cardiomyopathy. One of the important hot topics for the exam, my dear. So let's talk on them. And let me start by what is written in the notes to read all them together. So PPCM affects 1 in 3,000 live birth pregnancies. The etiology is unknown, but the condition is much more common in African women. So circle the African and circle the 1 in 3,000. Other predisposing factors including the advanced age, multiple pregnancy, multi-parity, and history of hypertension in pregnancy. Yes, I'd like to solve the important risk factors once again. The risk factors are categorized into two categories. There's a diagram that I'm showing, right, what is having in your notes, right? So some of the probable risk factors are the twin pregnancy, high parity, high gravidity, extreme of reproductive age, and prolonged tocolysis, preeclampsia, genetics, and obesity. So proposed risk factors are the smoking, hypertension, malnutrition, cocaine abuse, African ancestry, I said the African, yes, and also socio-economic status are also involved. So I'd like to give an SS box on the risk factors, because the risk factors are, knowing them facts are really important. Let's see some of the risk factors. So I'd like to start from here, from the SS box, my dear. So here's the PPCM, Peripartum Cardiomyopathy, the risk factors. If I'm saying the risk factors, I'm putting the risk factors once again. The rule of PPCM, just to remember once again the PPCM, it will be helpful. So let's see how it is helpful. Let's see mnemonics once again. So PP means the double P. So let's see how this PP means the P is helpful. If I'm starting with the P4, here's the pregnancy, means the multiple pregnancy. It is written multi-pregnancy. And P4 once again the parity. Yes, the multi-parity. So if I'm writing the multi, yes. So multi-parity along with the multi-gravity as well. Yes, multi-gravity. So multi. Yes, my dear. Next, once again, the P stands on, yes. And the point is really important. So I'm writing here the P for productive means the reproductive. I'm saying the reproductive age group, right? Means the, yes, advanced age. So these are the bundle packs that we need to remember. So yes, the multi-pregnancy, P for parity means the multi-parity, as well as once again the gravidity, multi-gravidity, and productive age. All them together that we need to remember. Next important P bundle packs that we need to remember. Yes, my dear, there's very important two P's. That is the prolonged tocolysis. And another P is the preeclamptic toxemia, the PAT. These two important, right? The bundle packs that we need to remember, my dear. So this is the P bundle pack. Next, I'm saying these are the basically the written in your notes, the probable risk factors. So I'm putting these are probable risk factors. So I'm writing. So once again, the PPs are the probable risk factors. Probable. So yes, probable risk factors are nothing but Yes, all the P's. So now let's talk on some of the proposed, right? Proposed risk factors. In proposed bundle pack, we have the CM, right? Cardiomyopathy. So this CM will be helpful to remember once again. At least C for cocaine abuse. All right, so I'm writing the cocaine abuse. And starts M for, yes, malnutrition. Malnutrition. So having the cocaine abuse, so we can write the smoking, a bundle pack of the other risk factors, the heart disease like the hypertension. So these two important things that we need to remember. And having an African, having the malnutrition, if you can remember in that way, so that will be helpful. And African having socio-economical status, socio-economical status. So this is the two bundle packs. Here's a cocaine and M for malnutrition bundle pack. So yes, this is the bundle pack, the proposed risk factors. Yes. Once again, we have in between two things, right? We can write obesity. The way I'm writing might just make your notes, that will be helpful. And genetics have some of the rules in betweens. So once again, what I said, my dad, just look at the board. The starting with the PPCM, the risk factors. We put the PPCM, the mnemonics, probable risk factors, and proposed risk factors. So start with the PP. So that is the bundle pack, my dear. There's a pregnancy, purity, and productive age. So this is the single bundle pack we need to remember. And second bundle will be P4. Yes, once again, the pad. Prolonged and pad. That's helpful. And also C for, yes, the cocaine, and M for malnutrition. Yes, we can remember in between the obesity and genetics. So these are the risk factors. So once again, remembering the risk factors, only the PPCM, that will be helpful, my dear. Now I'd like to talk on more further what is really the PPCM, Peripartum Cardiomyopathy. It itself says that peripartum means the partum is the delivery, so before delivery, and also after some period of the after delivery. So what is written in note, just follow me, my dear. The condition presents in the last month of the pregnancy or within 5 months post-delivery, whereas females with the idiopathic dilated cardiomyopathy presents in the second trimester. It's very important. Circle the idiopathic, circle second trimester when the burden of volume overload is greatest. Circle the volume overload. Second trimester idiopathic, just remember. So now talk the PPCM diagnosis requires the following 4 criteria. What is written? Presentation in the last month, circle the last month, or within 5 months of delivery, circle the 5 months. Second criteria, the absence of an obvious cause of the heart failure and previously normal cardiac status. And number 4, yes, echocardiographic evidence of the left ventricular systolic dysfunction, means systolic left ventricular dysfunction. So the diagnostic criteria for PPCM, a more extended form, it is written, heart failure within the last month of pregnancy or 6 months postpartum. We're simply saying that the 6 months and extended. Absence of the prior heart disease, similar. No determinable cause of heart failure. And fourth criteria, once again, there is the echocardiographic evidence of left ventricular dysfunction. That is evidenced by LV ejection fraction, EF, less than 45%. LVFS. LVFS means the fractional shortening, less than 30%. And LVEDD means end-diastolic diameter, less than 2.7 centimeter square centimeter body surface area. So this is the diagnostic criteria. So my dear, just look at the board once again. I'd like to give an important box of the diagnostic criteria, so you must remember. So let's do it. So writing the diagnostic criteria, once again, another SS box. So PPCM, yes. So itself says the Peripartum Cardiomyopathy. So here's the first diagnostic criteria, the peripartum. So this is very important. So the word the peripartum, it does mean 1 before the delivery plus 6 months postpartum. So we need to remember. And whenever the patient comes up with the SsCM cardiomyopathy, means the cardiac failure. PPCM, yes, they comes up with the cardiac failure. So heart failure. So this is the first point, of course. And second important point of the diagnosis is said that the absence of the prior heart disease and of course no determinable other causes of the heart failure. So yes, absence of obvious cause of heart failure. Any other causes? Other causes. And third, once again, previously normal hearts, means the absence of, once again, yes, any structural heart disease before the development of the heart failure. And last but not the least, number 4 important criteria that we need to remember, just put on 2.7, 30, 45. So this is, my dear, that we need to remember. But along then, the most important thing that we need to remember, there is a 2.7, 30, and 45. At least we need to remember the 45. So 2.7, 30, 45. Say with me. 2.7, 30, 45. Yes, the 1 plus 6. So that's all about the PPCM diagnostic criteria. So summary talk once again. If I'm saying the PPCM diagnostic criteria, just you need to remember the single talk, my dear. What is that? 2.7, 30, 45. So if I'm giving a summary talk of the diagnostic criteria, so we can write, so if I'm writing these here, the diagnostic criteria summary talk, the 1, 6, so I'm putting 1, 2.7, then 6, 30, 45. Means these numericals that we need to remember. So these 1 and 6, we know about it. So here's the 1 month before delivery and 6 months after delivery. 2.7, yes, once again the LVEDD, and 30 is an LVFS, and once again the 45, once again LVEF. So we need to remember all them together before going and making our diagnosis of PPCM, my dear. Yes, my dear doctor, I'd like to talk on management of PPCM, which is very much important. Let's talk on then what is written in your notes, right? The management is conventional heart failure therapy. SC inhibitors should be avoided during pregnancy. Patients with very dilated or poorly contracting left ventricles should be anticoagulated, as the risk of intramural thrombus is high in PPCM, means the peripartum cardiomyopathy. The prognosis is guarded with up to 25% of the females dying in the first 3 months. Approximately 50% recover full cardiac function within 6 months. Around 5% of the females require cardiac transplantation. future pregnancies should be avoided in females who haven't recovered the normal cardiac size and function. So, my dear, I'd like to talk on one of the important flowchart that is given in your notes. Just follow me what is in your flowcharts. Yes? So let's talk on them, the flowcharts, starting with the history. It is written the history starts with the heart failure symptoms, question mark. Symptom onset last few months of pregnancy or the first few months after the delivery, question. No previous history of the cardiac disease means the question, the diagnostic criteria of the PPCM. Symptoms of heart failure, any previous cardiac disorder, and the symptoms start few months, means 1 month before delivery and after 6 months after the delivery. If the question answer is yes, then we'll do the examinations, clinical examinations. If it is no, then consider the alternative diagnosis. If it is yes, we'll do the clinical examination. Signs of systolic heart failure is found or not. After that, if you found the patients either normotensive or hypertensive, if it is hypertensive, that consider, yes, once again, the preeclampsia. So in clinical examination is also, we are getting the other findings. So consider the alternative diagnosis. Same thing, if you get the hypertension, we'll get, yes, in clinical examinations, consider the preeclampsia. If it is normotensive, then we'll do the, yes, the transthoracic echocardiography. Means the history, clinical examination, and transthoracic echocardiography, the steps will be helpful to reach or diagnose the PPCM. Transthoracic echocardiography, it will shows, right? If the LV ejection fraction more than 45%, yes, consider the alternative diagnosis. If once again the LV ejection fraction less equal 45%, then yes, we'll do the list of investigations. Yes, we'll do the chest X-ray that can give us, right, especially the postpartum, right, cases, the chest X-ray. So you can get the cardiomegaly, we can get the pulmonary edema, and in case of ECG, we can get the left ventricular hypertrophy with some of the STD abnormalities that we can get in case of cardiomyopathy. And some of the labs, once again, CBC, creatinine, electrolytes, TSH, LFTs, and NT-proBNP, and also CRP and HIV. These are the tests can be done, yes, to exclude the some other differential diagnosis, yes, can cause the cardiomyopathies. So these are to exclude the diagnosis. But basically, most important, the LV ejection fraction less equal 45% is the most important criteria that we need to remember, my dear. Adjunct studies is written in your notes. Cardiac MRI, useful when echo images are non-diagnostic. May provide the prognostic information, cardiac MRI. So circle the cardiac MRI, we call the CMR, when echo images are non-diagnostic. In that case, we can do the cardiac MRI. So right ventricular biopsy, useful in patients with ventricular tachycardia or high-grade heart failure in patients who fail to respond to the optimal medical therapy. So circle the fail, circle the medical therapy. Yes, having the VT, circle. Yes, we should do the right ventricular biopsy. So these flowcharts will be helpful for the diagnostic purposes. Yes, my dear. So for the diagnostic flowchart, what you learn, one of the most important talk that starting with the history, then the clinical examinations, then talk about the investigations. So if I'm putting from the box of the diagnostic approach, or we can say the approaches, so starting with the history, yes, then go for clinical examinations. So history we're looking for, yes, of course, the important criteria. You see the 1, 2, 3. So we are looking for basically 1 plus 2 plus 3 important criteria. And examination, of course, the heart failure features. But most important, we are looking for, of course, the heart failure features, and you're looking for, of course, just remember to look at the hypertension. If it is hypertension, basically it will go to the PET to diagnose. So just write down the way I'm writing. Next talk is investigations. So we do the investigations. The diagnostic investigations that I'm writing on the right hand side, there's the transthoracic echocardiography. And here's once again, that is less equal 45%. Yes, that is our diagnostic part. If it is more than, here once again, more than 45%, there is an alternative diagnosis. So here's the less equal 45%, that is the diagnostic criteria. So that is the box, my dear, we must remember. Yes. So starting, yes, points with the history. That's this box. Starting with the history, then examination, and third, the investigation. In examination, of course, we look for the diagnostic criteria and investigate further. So, but we look for hypertension to exclude the preeclamptic toxemia. Yes.